Thanks, Dr. Wang, for this invitation to be the speaker today. It's really exciting to be back at Michigan, and I'm really happy to chat to all the students and also I see some familiar faces in the crowd. So I'm going to just give you like a brief, in this first half, I will give you a brief introduction to me and my journey and what I do right now and some of my research, just a flavor of it. And then in the second half, I'm happy to answer any questions that you have on any level. So my journey started back home in South Africa. I graduated in 2006 from the University of Cape Town. Sorry, the picture's a bit blurry. I realized I was looking through my own photographs and I was like, I don't have a great picture, but the University of Cape Town is a really beautiful campus. It's actually set on Table Mountain. And so you have this, like, on the campus. This building actually here is the maths department, and then the stats department is a little bit higher up there in the mountain. So I started with my undergraduate degree was in statistics and applied mathematics. And during my time in Cape Town, I realized I actually wanted to focus on health research and applying the statistics and mathematics that I'd been learning to health research. And so then I applied to graduate programs in the US, and I came to the University of Michigan. And as Dr. Wang said, I did my master's and my PhD in our department, graduating in 2014, finishing my degree in 2013, I defended. And I did my thesis with Susan Murray in our department, and my thesis was focused on restricted mean analysis across multiple follow-up intervals. I would say during my time at the University of Michigan is when I really started getting into collaborative research and developing statistical methodology that is very focused on solving clinical problems. So as a graduate student, I worked with the pulmonary division. And so I got experience in learning how to analyze completed studies, design trials, working directly with investigators to answer their scientific questions of interest. And some of those questions then fed into the work I did in my thesis, and trying to come up with measures of restricted mean survival that use multiple follow-up intervals in a more efficient way, and that allows us to incorporate multiple different events that occurred at recurrent time points and doing testing. So all the analyses that we did were based on a lot of collaborations that had come up as a result of working with the pulmonary division. And so then to continue that, I went down to Texas to do my postdoc. And I also then, after the postdoc, became research faculty at MD Anderson Cancer Center. And there I continued this kind of trajectory of working very closely with clinical collaborators and developing statistical methodology that answers their specific questions and solve some of the gaps that we've discovered during that research. So my postdoc was with my advisors, Drs. Kim On-do and Ziding Feng. And some of the projects I worked on then were involved in biomarker study design. So how can we introduce interim analyses for futility when we're evaluating biomarker panels for early detection, and longitudinal biomarker screening algorithms for improved early detection of cancer that I'll talk about now. And essentially a lot of the work that I did in my postdoc and then continued working on became the preliminary data for my R01 application that I put in. And so at MD Anderson is where I kind of shifted my focus away from pulmonary diseases towards cancer, and very specifically early detection of cancer. And so with Ziding Feng and his involvement in the Early Detection Research Network, I became more involved in the Early Detection Research Network and have developed a lot of collaborations that have then continued and have been very fruitful. Then in 2019, I moved to Dana-Farber Cancer Institute, and I became faculty in the Department of Data Science. Since then, I've kind of had like a split in what I've been doing. I kind of had that at MD Anderson as well, in terms of where my focus was and the types of projects I worked on. But here specifically, I work with women's cancers, the Susan F. Smith Center for Women's Cancers and the investigators there, and had been involved in more clinical trials research. So I kind of split my time between the clinical trials research within the Women's Cancer Center, and then my own research that is more focused now on early detection of hepatocellular carcinoma and collaborations and my own projects in that area. So in terms of my work with investigators at the DanaFarber, I co-lead the Biostatistics Cores for our Breast and Ovarian SPORE. And we have a pretty big group here of statisticians that I supervise that work collaboratively with the breast group and the GYN departments at DanaFarber. And so I'm kind of getting that leadership and mentorship experience in my new position here at DanaFarber. And then the things that I developed and I brought with me were my projects in early detection of HCC, hepatocellular carcinoma. And actually those projects I work with investigators across the country. So when you're talking about early detection of hepatocellular carcinoma, your collaborators are actually hepatologists, because they're the ones that are doing the surveillance for HCC. And so I'll go over some of my collaborators and things, but they're basically all over the US. Which has been really phenomenal in being involved in some of the really impactful research that is going on in this area and being able to make an impact. So I'm going to talk a little bit about the area that I hope to make through these collaborations make an actual impact. And so it starts out with, okay, so the early detection of hepatocellular carcinoma is really important because we have a cancer whereby when you are diagnosed with late stage HCC, your prognosis is very poor. So for patients, once they become symptomatic, we don't, at this current time, we do not have good treatment options for them. However, if we are able to detect it at an early stage, then we have potentially curative therapies available to these patients. So for example, if you are able to get a liver transplant, then your survival rates are, 5-year survival rates are almost about 80%. Similarly, if you can do a surgical resection of the liver, you have very high survival rates in these patients. So the goal is we want to be able to detect these patients when they have early stage asymptomatic HCC. And how we do that is by finding clinically useful early detection biomarkers. So our population in HCC, we have a well-defined population for who is at highest risk for developing HCC. And these are patients with cirrhosis of the liver. So they already have a damaged liver from various causes. And now they become significantly higher risk, about 2 to 3% annual incidence of HCC in this population. So if we have an early detection biomarker that is increasing at these early stages, either undetectable microscopic HCC, or once it becomes CT or MRI detectable, then by regularly seeing these patients, we would be able to pick up that we have this increasing biomarker and thereby hopefully increase the likelihood that we actually detect them at this asymptomatic early stage HCC, whereby we can offer them curative therapies and affect the mortality rates associated with this cancer. So the current surveillance in HCC is based on the American Association for the Study of Liver Disease guidelines, whereby ultrasound is a mandatory component of the surveillance, and it's recommended to be every 6 months. And they have a biomarker at the moment called serum alpha-fetoprotein, AFP, which is based on the guidelines optional, but it's actually very commonly done. And so if you have either something suspicious on your ultrasound, or you have elevated serum AFP, then your result is you have a positive screening result, and the patient is sent for CT or an MRI, and that can actually be used to diagnose HCC. HCC does not require an invasive biopsy, and that affects how we think about the kind of the performance of these biomarkers, because the consequences of a positive test is not as invasive as having to do a biopsy. It's an imaging modality for diagnosis. So the question is now, based on this current surveillance guidelines, we're still not doing a very good job with HCC surveillance. We still have lots of patients diagnosed at late stage HCC. So our goals are to improve the early detection of HCC through surveillance. And so some of the ways we're going to be doing this is adding more biomarkers. So there are 2 HCC biomarkers that are FDA approved for HCC risk. They're used very commonly in Asia, not as common in the US. And so we have a few studies where we're trying to evaluate these biomarkers. And my work is focused on, now we don't want to just think about the current level of these biomarkers. Like I showed you in the figure before, we want to understand the trajectories, and we want to be able to use the trajectories to signal onset of cancer. And we want to be able to incorporate the clinical information that we have readily available on all these patients. They get regular liver function tests. The etiology of their disease may potentially affect how these biomarkers work, as well as some clinical factors like age, gender. Men have higher rates of HCC development than women. So the work that I did basically was leading up to this a grant that I submitted in 2018 that is basically proposing to develop two HCC screening algorithms simultaneously, using different methodologies, different cohorts to develop them, potentially different settings for their usage, but to increase the size of the toolbox we have for this problem. So I'll introduce these algorithms very briefly, but the key part I wanted to highlight to this slide is the methodology research would not be possible unless I had these collaborations whereby we could actually have the cohorts that are required to be able to develop and then validate these algorithms and determine whether they are useful for actually moving forward into prospective studies. So in terms of the collaboration, so Dr. Anna Locke is at University of Michigan. I actually started working with her very early on in my postdoc on my first paper in this area, and she's been an amazing collaborator, so supportive ever since. And so she was one of the lead PI or one of the lead PIs of the HALT-C trial. And the HALT-C trial was a randomized clinical trial, but it did a really good job of creating a biospecimen repository and a well-defined cohort where we can do a lot of this methodological development. And so we've been using it quite extensively in that. At the VA and Baylor, as well as Kaiser Permanente in Northern California, we have these electronic medical health record cohorts that have been constructed. And so Dr. Hashem El-Sarrag had an R01 that I worked on as a postdoc, and they developed these cohorts where it was curated electronic health record data. And so one was from the VA, the other was from Kaiser Permanente in Northern California. That was Dr. Douglas Fawley's cohort. And we put those two together. And within this, Dr. El-Sarrag's R01, we did a project more like a simplified version of the algorithms I'm talking about. So instead of trying to incorporate the entire trajectory of AFP, we just used the change from the last year. So, but we saw useful results, and we were able to incorporate other clinical information. So for the, I previously developed a fully Bayesian algorithm. And that algorithm was published a few years ago now, but there's still some work to be done in for that. So for example, we want to be able to explain some of the variability in the HCC early detection biomarkers that is not actually due to the development of HCC, but the underlying liver condition of the patient, the cirrhosis. And so by incorporating clinical information, these liver function tests, and explaining more of the variability that we're seeing in these trajectories, we can then have a cleaner signal for the onset of cancer. And so that's what we're going to be doing with those cohorts. Whereas with the multivariate PEB algorithm that I'll introduce, it's more focused on combining multiple early detection biomarkers. And so these two parallel approaches, either for each of these algorithms, we're going to do validation in 2 studies. The Early Detection Research Network has funded the hepatocellular carcinoma early detection strategy study that has 1,500 patients. It is now maturing, and we're actually analyzing this data now. And so we're just going to apply these algorithms and see, okay, how do they do in a matured cohort where we have multiple biomarkers, all this clinical information? Do we need to do any further refinement, because the cohorts that we use for development have their own kind of characteristics that might cause, that might require us to do re-estimation of some parameters of the models. But then the goal would be to do a full external validation in the Trans-Texas Hepatocellular Carcinoma Consortium. That is, the head study is Dr. Jorge Marrero's, is the PI, and the Texas Hepatocellular Carcinoma Consortium is Dr. El Sarag is the PI. And so between these 2 studies, we hope to have a good answer of, are these algorithms that we've developed clinically useful? And can we actually move forward to a prospective study where we test out, because these are all retrospective studies. The biomarkers and all of this information was not used to actually screen these patients. They were just screened using the standard of care. And so prospectively, do we have evidence based on these retrospective studies to design a prospective study? So just in terms of the algorithms, I think I'm getting close to my time of my half an hour up, so I'm going to go very briefly. There are some references over here, but the idea is that a clinician, an experienced hepatologist, will be doing this in their head, essentially. And I've had a lot of discussions with this. They don't necessarily, even though when you look at papers evaluating these biomarkers, they all look at just a single time point evaluation of the biomarker, estimating sensitivity and specificity, what's the performance. But when they actually have a patient in front of them, they do look at the trajectory. For alpha-fetoprotein, they're not really, like if a patient has a very low level, and even if it starts increasing, but it's below the threshold of 20 nanograms per milliliter that you'll see in most papers, they'll still flag that as, okay, I think this patient actually needs to go have a CT or an MRI. So what we want to be able to do is formalize that into an algorithm that can be used more widely. And so you don't need your experienced hepatologist to be paying attention and to make sure that within the clinical care that gets caught, that it's actually part of the standard of care. And so to be able to identify if a deviation has occurred, we specify a model for what we expect the behavior to be. So if you do not have HCC, if you just have your cirrhosis of the liver, you have your patients are coming every 6 months, and what is their within subject variability? What is the variability across the patients? These are very heterogeneous patients. Their reasons for why their liver why they have cirrhosis of the liver and high risk of HCC is very different and can affect these biomarkers. So by understanding how we expect them to behave when they don't have HCC, you can then identify a deviation from that expected behavior. So for a single biomarker, this was developed in 2003 by McIntosh and Urban. And so we applied this to HCC, to the HELP-C trial, and we saw, okay, this does a really good job of just improving, taking existing information you've already collected, and we increased the sensitivity from 60% to 77%. So, and essentially what you're doing is, instead of just using a fixed threshold for all the patients, like, so the example is just a C2, you actually have this PEB rule where each patient has their own threshold. So given I know the trajectory of the patient to date, what is their, is what I'm seeing a significant deviation? And when you have a single biomarker, then you can, and you say, okay, I want a certain false positive rate that's acceptable, which in HCC is 10%, then these are all uniquely identified. But when you go to multiple biomarkers, then you no longer have a uniquely identified threshold, and so you have to make additional assumptions. And so what we do is we think about, okay, now how do we want to combine the biomarkers? And we have chosen to use logic rules to combine biomarkers. The reason for that is essentially we want to use the same kind of concept of an individually tailored threshold for each biomarker for each patient. And so with logic rules, we also get, between using OR rules and AND rules, we can come up with quite a flexible set of approaches for combining the biomarkers. And so what we do is now instead of once we specify the model in the control patients, we no longer have unique thresholds. So we turn this into a constrained nonlinear optimization problem where we're maximizing the positivity of a positive screen if the patient has onset of cancer while still controlling the false positive rate. And essentially in the PEB approach, we're trying not to specify this trajectory. So we're trying to be a more minimal model for how the biomarkers change during this crucial period where you may or may not have sufficient data to do it, depending on the setting, of what that change, that shape of the change actually looks like. So this is different from our previous approach that we've proposed and that we're refining and building on as well, which is a fully Bayesian screening algorithm. And so in a fully Bayesian screening algorithm, you're calculating the posterior risk for each patient at each screening time. And it's based, in order to do that, we have to specify a model for what is the biomarker, the expected behavior of the biomarker in patients who have HCC, and the expected behavior of the biomarker in patients who don't have HCC. And so this one is under the setting where we do have sufficient data to be able to model that trajectory of the biomarker after the onset of cancer. And so that's why we wanted to take these two approaches simultaneously, because they might have better utility in different settings, and it gives us a bigger toolbox in terms of which one performs better in which approaches and for different types of biomarkers. And so we did a head-to-head kind of comparison of these approaches in the HALT-C trial, and actually in the 1 year prior to clinical diagnosis, where in the case of a fast-growing cancer like HCC, this is the time period where we expect that if we get a positive screen, that this will actually be able to identify the HCC. You see that, so the MPB algorithm is the multivariate PEB algorithm, and the multivariate fully Bayesian are essentially the same. Both do better than univariate versions of these algorithms that have been previously proposed, and better than a single threshold approach that ignores the screening history of the patients. So this is just to give you a flavor of these kind of algorithms, and our goal of these is to basically get these, by further refining them, adding more biomarkers, adding more clinical information. We want to be able to get to a level of sensitivity, this is at 90% specificity, that actually gets us an acceptable performance of the algorithms that can move forward prospectively. So that's the goal of my R01, and all the collaborations that I'm involved in, to some extent or another, is essentially also working towards this goal of having an early detection screening strategy for HCC that can be improve mortality for this cancer. So I just want to thank my clinical collaborators. I mentioned them here, Anna, Hashem, Jorge, and Doug are all a part of my R01. And then Amit Singhal at UT Southwest, I'm on his grants. I'm a collaborator on his grants. And as well for Dr. Fasiha Khanwal at Baylor. She has a UO1 that I am a collaborator on. And then my statistical collaborators is my postdoc advisor. We continue to work in this area together. Zining Feng, who's now back at Fred Hutch, and Francesco Stingo, who was also at MD Anderson with me and he's moved back to Italy. He's at the University of Florence. He taught me how to be a Bayesian because I was not a Bayesian when I joined MD Anderson. And I just want to thank the NCI for the various funding that we've received to be able to do this research. And I am happy to take any questions.
That's great talk. Thank you so much for sharing this with us. And we will go with the first round of questions related to the talk, and then we will stop recording and we will go with the discussion and chatting. So any specific question related to the talk and the research?
Hi, Nabihah, it's Susan.
Hi, Susan.
It's so great to see what you're up to. And I'm just wondering, have you started looking at machine learning kinds of algorithms to apply to your data?
Yeah, we're actually, I was thinking about it because for the VA and the Kaiser cohorts, those are like really large data sets where you could potentially use these machine learning algorithms. We have a collaboration with investigator at Microsoft. And so we've had some discussions. I think one of our challenges has been that the VA systems are very hard to get like other people, like they have very like specific things like, you know, but now that I have an R01 that's funded and we have permission to transfer some data and all of that kind of stuff. The goal is to try out some of these machine learning algorithms. They weren't originally part of the grant, but definitely, because I mean, essentially, to a certain extent, if you want to be really broad about the definition of machine learning, I mean, these algorithms are machine learning. They're basically taking data, they're updating it. They're more parametric, they have more model-based as opposed to like the neural networks and things. But in the terms of the concepts and personalized decision-making, it fits well within it. So yes, that's the next step. And if anyone wants to do that as part of their postdoc research, please send me an email.
Does that mean you have open postdoc positions?
I do. I'm looking for a postdoc. Mm-hmm.
So Nabihah, when you are talking about the different projects at the DanaFarber, do you know like most of their design right now are still just one-stage design, or are they moving on to the two-stage designs for example, treatment adaptation or dynamic treatment regimes?
I'm not as much for those, I would say. So so I work on investigator-sponsored trials. Investigator-initiated trials, sorry. And so those tend to be phase 1, phase 2. So since I joined, we have moved away from the 3+3 design. And so all the trials I've designed so far, we've used some kind of, like, so we've used Bowen a lot. Since I came from MD Anderson, that was the one I was very much exposed to. I would say that depending, so within the group, there hasn't really been an opportunity yet to do the treatment adaptive, but I would say that by introducing the more novel designs now for just the phase 1s, we do have a much more receptive audience to a more, different study designs and approaches.
Got it. Yeah, good to know. I'm just curious about, DanaFarber and MD Anderson, what they are doing for the different trials.
I would say that, I mean, in other disease types, you definitely are having more of it. I don't know whether you know Dr. Lorenzo Trippa. He's at DanaFarber as well, and I think he is involved in a few of the studies that have the adaptive treatment regimes as part of theirs. It just hasn't quite happened in the women's cancers yet.
Got it. Good. Other questions?
I'll stop sharing.
All right, so thank you very much for this wonderful talk, and we'll stop recording right now, and I'm going to open the floor for the free chatting. Okay.